When the holidays start to feel a bit repetitive, reach for a Sprite Winter Spiced Cranberry and put your twist on tradition. A bold cranberry and winter spice flavor fusion, Sprite Winter Spiced Cranberry is a refreshing way to shake things up this sipping season. And only for a limited time. Sprite. Obey your thirst.
This episode is brought to you by Indeed. You're ready to move your business forward, but first, you need to find the right team. Start your search with Indeed-sponsored jobs. It can help you reach qualified candidates fast, ensuring your listing is the first one they see. According to Indeed data, sponsored jobs are 90% more likely to report a hire than non-sponsored jobs. See the results for yourself. Get a $75 sponsored job credit at Indeed.com/podcast. Terms and conditions apply.
Hi, and welcome to the Med Prep to Go USMLE Step 2 podcast. I'm Dr. Raj, a quadruple board certified doctor in pulmonary, critical care, sleep medicine, and my jam, internal medicine. And I am super excited to be doing this Step 2 podcast. I've been teaching for over 20 years, doing all levels of board review. So anyways, I want to read our mission statement. So we at Med Prep to Go believe that our mission is to improve medical student wellness and reduce educational debt by providing high-quality USMLE questions in an online and audio format, by making medical education material available to study on the go. We at Med Prep to Go strive to give you time back in your day to focus on your health and well-being. So how do we do things here? We will actually pick subjects and we'll give 3 questions in a row right from our amazing bank of questions. And you can always go to the website and read the questions along with us and read our explanations. So for those of you who listen to our podcast, you know how my style. I like to always add in a little something because I always feel there's always room for a little more teaching. So I hope you guys and gals appreciate it. Today we're doing endocrinology. I love endo, one of my dark horses. We're doing questions 4, 5, and 6. Are you folks ready? All right. Cool. So here's question number 4. This is a 65-year-old woman presents to the clinic for an annual physical exam. She has a history of type 2 diabetes, hyperlipidemia, hypertension, chronic kidney disease, stage 3. She is currently taking only metformin, 1,000 milligrams twice a day. Recent lab work includes a fasting blood glucose levels at 180. So, you know me. Time to throw my own little thing in there about teaching. If we're doing a fasting blood glucose, that if you want to diagnose type 2 diabetes or diabetes in general, it's going to be a level greater than 126. And this one's 180 on a fasting. So, all right, she's a type 2 diabetes doing a fast at 180. That's not a good thing. And they do the hemoglobin A1C. So hers is 8.5. That is definitely elevated. So one-dimensionally, if we're trying to diagnose type 2 diabetes, a hemoglobin A1C above 6.5 means, hey, you probably have diabetes. So kind of gives this hint that she's not, doing well with her blood glucose. And on top of that, she's got all this metabolic syndrome going, right? She has hyperlipidemia and hypertension, and the kidneys aren't doing well. Her urine albumin to creatinine ratio is greater than 500. So this is key. Diabetes can affect every single organ in the body. And of course, when we talk about the microvasculature, I think of the eyes, I think of the nerves, and definitely I think of the glomerulus in the kidney. So all this protein is getting filtered, which is a bad thing, going into tubules and damaging the tubules. So of course, there's cutoffs to know, hey, what is the normal, air quote, urine albumin creatinine ratio? Of course, in general, you don't want to have any type of albumin in the urine, but in this case, it is definitely elevated. It's above 300. It's actually 500. So what do we do in this individual? We're going to be starting losartan, and that's part of the question. So losartan is an angiotensin 2 receptor blocker. She's on 50 milligrams of this. And oh my God, I totally forgot there's a question here. Which of the following medications should be added to slow the progression of chronic kidney disease in this patient? So this is going to be huge because, what do we worry about? Say it. Dialysis. We definitely want our patients to remain off dialysis as much as possible. So what are our choices here? A, we can start an angiotensin converting enzyme ACE inhibitor. B, glucagon-like peptide 1 GLP-1 agonist. C, loop diuretic. D, hey, we're doing good. No other medications are indicated. Or E, a sodium glucose co-transporter 2 inhibitor. So let's kind of go over this together. So A, ACE inhibitor definitely is going to be the wrong answer. Why? Because patients already on a what? Oh, you nailed it. ARB. You don't want to be combining these RAS drugs together. And RAS, for those who don't know, are renin-angiotensin system. And sometimes RAS is spelled with 2 A's, renin-angiotensin aldosterone system. But take-home message is you can't combine ACEs and ARBs together. That's a big super no-no. So A is wrong. B, don't get me wrong, GLP-1 agonist. Everyone loves Ozempic. I can't believe I just sang on my podcast, but no, there's no role when we talk about, putting on GLP-1 agonists when we talk about having decreasing chronic kidney disease. Good for obesity and stuff and other things, but not this. C, loop diuretic. No, that's not really going to slow the progression down. So this is not a loop diuretic. D, no indication. No, you got a high albumin-creatinine ratio despite being on an ARB. You got to add something on. So test-taking skills, the right answer is E, but no, beyond that, it is the correct answer. Sodium glucose co-transporter, SGLT2 transport inhibitors are definitely going to be the right answer. Why? It really goes into beyond just memorizing the guidelines, is that when you give these categories of drugs, it's hard to explain, but I'm going to do it anyways. How does it actually save the kidneys from getting worse? It all goes back to something called the juxtaglomerular apparatus, which connects the afferent arteriole with the distal convoluted tubule. And when you give these SGLT2 inhibitors, it's going to start dumping more sodium and glucose into the urine. That's what it does. That's why we use it for diabetes, and it helps out with heart failure. But what is it going to do is that it's actually going to decrease the flow from the afferent arteriole going to the actual nephron itself. And because it's going to have less pressure going in there, because what's going to happen when the distal tubule sees all this sodium and all this fluid going to the distal tubule, it's going to actually want to constrict that afferent. So less flow and pressure are going to damage those tubules. So that's why these SGLT2 inhibitors are going to be the right answer for question number 4. So right answer is E. E as in Edward, SGLT2 inhibitor, for exactly the same reasons I talked about. So let's do another question. All right, let's go to question number 5. So in this case, we have a 33-year-old woman presents to the emergency department with a rapid onset of confusion, severe abdominal pain, and vomiting over the last 1 hour. A collateral history from her partner reveals that she has been having unusual salt cravings and lightheadedness upon standing over the past 2 months, but had put this down to her recent increased stress from work. Okay, that makes sense. So confusion, severe abdominal pain, vomiting. And she says, wow, I'm trying to make sure salt cravings, lightheadedness. But says it's all from stress from work. Okay, I guess. Past medical history is significant for Graves' disease. So that patient's going to be hyperthyroid, which is well controlled with carbimazole. All right. Vital signs are low grade at 100.4 Fahrenheit. Blood pressure is low at 80 systolic or 59 diastolic. Heart rate is 92. Respiratory rate is 18. On physical exam, the patient had a capillary refill time of 4 seconds and dry mucous membranes. A generalized bronze skin tan is also noted. I know where this is going. And I'll tell you, the bronzing skin is not hemochromatosis. I'll tell you that. Patients pertinent lab studies included the follow. Sodium is low at 128. The potassium is high at 6. Glucose is going to be on the lower side. Intravenous access is obtained, and the patient is transferred to the intensive care unit. Which of the following is a definitive treatment for this patient? So, is it A, give some air quote normal saline through the IV? Is it B, give some dextrose to increase the blood sugar through the IV? Which definitely would help too. Is it C, give some intravenous hydrocortisone, give some steroids? Is it D, insulin through the IV? Or E, give some norepinephrine? So let's go through here. So I think we could talk about multiple things that seem right in this case. Which ones definitely sound as a really horrible idea? If you have a low blood glucose and you're giving insulin, yeah, you'll probably get sued and have to go to a court and talk about it. So it's not going to be D as in dog. I know the patient has low blood pressure, but just giving a pressor E, which is norepinephrine, brand name Levofed, wouldn't solve the underlying thing because the question says definitive. So it's not going to be that. Giving saline, if you have low blood pressure, I always say give some IV fluids. That's definitely a correct answer. It's the phrasing of the question. Is it definitive? Is it treating the underlying cause? No, but many people could argue, give some fluids, man. He's hypotensive. So that's going to be A. So I wouldn't say A is the right answer. So it really comes down to B or C. And once again, everyone could argue, you know what I mean? So, it's the word definitive. That's what makes it really hard, because if you have low blood glucose, I'm going to give you glucose. There's no questions asked. So it's really tempting to pick B as in boy, because you could die from being hypoglycemic. But I'm thinking my test taking skills hat, what is this question trying to say? You're bronzing of the skin. Oh boy, that means that you're going to have some kind of adrenal insufficiency. And what adrenal do I think about? You have probably a problem with the adrenal itself, And so that's going to be where, hey, your pituitary is going to be secreting lots and lots and lots of ACTH and some melanocyte stimulating hormone. So with that being said, you have a primary adrenal insufficiency. You definitely could think about that bronzing of the skin. Also, if you take out the adrenals, then you're going to lose that renin-angiotensin system. The sodium's going to be low. Potassium's going to be on the higher side. So giving steroids in this case is definitely going to be the answer. It will help out the blood pressure go up. It will eventually help out the glucose. But of course, if someone's symptomatic from hypoglycemia, there are certain things you might want to do, which is give glucose, but it definitely wouldn't be definitive treating the underlying cause. So even though I feel already that there are going to be some people that are arguing what the right answer is here, I feel based on the question, the word definitive, you got to go with C and give this patient some steroids, okay? And don't get me wrong, giving some steroids will do what to the glucose? It will bring it up too. It will definitely bring it up too. But I'd feel that on the test, look the way I talked it out, I would pick C, give some steroids.
In Walmart's Newville, time was ticking away. Only a few nights left till the big holiday. But last-minute gifters had no need to worry. Walmart Express Delivery got their gifts in a hurry. From Nintendo to Nespresso and Lego flowers, they could check off their lists in as fast as an hour. All of Newville, East, West, South, and North could order gifts up until 5 p.m. on December 24th. So this holiday, just do as the Who's do. With gift delivery this fast, they all gasped. From Walmart? Who knew? Subject to availability, terms and fees apply.
Oh, Hilton stay, oh, Hilton stay. Your beds are soft and cozy. No lumpy couch, no stiff futon, no shower line at crack of dawn. Oh, Hilton stay, a holiday you're saving.
When you want holiday comfort you can count on, it matters where you stay. This season, enjoy spacious, comfortable rooms and friendly service when you book with Hilton instead. Hilton for the stay.
All right, here's question number 6. So we have a 21-year-old woman presents to the emergency department via emergency medical services after being found somnolent and difficult to arouse in her dorm room by her roommate this morning. That just sounds scary. That's going to be on some 2020 news special. I'm already scared of this question. Past medical history is only notable for heavy menstrual periods. Current medications include only taking some birth control, some estradiol, norgestimate, oral contraceptive pill. Her father has hypertension, hyperlipidemia. The mother has rheumatoid arthritis. Patient drinks 3 alcoholic beverages only on the weekends. Yeah, right. I'm just joking. Does not use tobacco products. The patient's roommate states she occasionally smokes marijuana and is not aware of any other substances. The patient's roommate states for the last week she has been unusually fatigued and her vision has been blurry. The patient attributed this to spending many hours on her computer writing her final paper for her senior project. Her roommate states she has also been drinking significantly more water and reported intermittent abdominal pain and general malaise. Vital signs is a temperature of 100 Fahrenheit, 100.0. Blood pressure is 95/62. Heart rate is 110. Respiratory rate is 28. Physical exam reveals a somnolent woman who arouses to sternal rub and unable to follow commands. This is not good. Her pupils are 4 millimeters bilaterally and are reactive to light. Respirations are exaggerated and deep. There is a normal S1 and S2, and the heart rate is tachy but regular. Skin is erythematous and warm to touch diffusely. The patient has dry mucous membranes, increased skin turgor. Relevant findings include a pH of 7.12, patient super acidemic, CO2 of 18. So we know it's not a respiratory issue going on. The PaO2 on room air is 79, which is totally good. That's the P little AO2. Potassium is on the low side at 3. And the glucose is 68. So yeah, I wouldn't mind a bicarb. I wouldn't mind a little calculate the anion gap. They didn't put it in the question, but I can tell you one thing. They try to really piece this together. So it's kind of a good board question where they make it do a couple of assumptions. So if you piece together that you have a 21-year-old person, abdominal pain, who's very tachypnic, who is acidotic, with a potassium is low and a glucose of like 682. Yeah, what does that scream in? DK to the A, diabetic ketoacidosis. That's what I'm thinking. So obviously you need a bigger workup, and there were a lot of red herrings in the vignette to make you think of other things. Which of the following is the most appropriate next step in the management of this patient? All right. So what are my choices? Give him some normal saline. And I hate the word normal. I got to tell you, because I'm a critical care doctor, 0.9 NS is far from normal. Why? Is because how much sodium is in normal saline? Yeah, 54 milliequivalents. And 54 milliequivalents of chloride. That's so far from normal because it's not our normal sodium. But should we give this patient some volume? All right, A. B, give some normal saline with some potassium. I do like giving potassium because if this turns out to be DKA and someone wants to stop the ketosis, what do you have to do to stop the ketosis? Yeah, you got to give insulin. And if you give some insulin, what's going to happen to the potassium? Oh, dude, it's going to get shoved in the cell and serum potassium is going to drop. There's going to be so many U waves on your ECG. You're going to get some arrhythmia. So I like B because there's potassium. C, normal saline with bicarb. When there's an anion gap metabolic acidosis. But once again, I wish they gave us the sodium, the chloride, and the bicarb to calculate a gap. There's an assumption that we're going to assume that this is an anion gap metabolic acidosis, that we usually don't give bicarb to when you have a gap. You could if the pH is like, super duper low, like definitely below 7, but you want to correct the underlying cause. So just giving bicarb up front is not going to be the answer. You got to stop the ketosis. So C is wrong. Giving insulin by itself, which is D, just insulin, that'll drop the potassium. That's a bad idea. So C is wrong. D is wrong. Initiating an SGLT2 inhibitor. I don't know where that came from. We probably need a filler for choice E. Just joking. But that's definitely wrong. So it really comes down to, of course, when you talk about how do you manage DKA, you want to give fluids, but you got to watch that potassium. And with the assumption you're going to be giving, some insulin too, the most important thing here is to choose letter B as in boy and give the Isotonic fluids with potassium, give with potassium. Answer here has to be B. I'm going to view my answer because when I do the questions with you folks, I like to mess up. I always like messing up. So I always just do it on the fly. Then I look at the answers like real time. And yeah, the right answer is B as in boy. Cool. So I hope you realize I have a lot of fun doing these podcasts because doing questions, studying, for your boards and USMLE is actually really fun. It really helps out, going to the future and helping out your patients. So I'll see all you folks next time on my next set of questions. And please check out the MedPrep to Go podcast and medprep2go.com website and follow me on social media.